Hey there, good afternoon. Guess what time it is? It is 3 o'clock. No, gosh, 3 o'clock on the West Coast. That means 4 o'clock on the East Coast. No, gosh, what am I saying? 3 o'clock on the West. Let's start again. Hey, how you doing? Dr. Randy Fink here, and this is Fertility with Fink and Friends. It is 4 o'clock Mountain Time, which means 6 o'clock on the East Coast and 3 o'clock on the West Coast. Boy, I'm having a hard time with the telling of time in basic mathematics here today. So good day. Nice to see everybody on this Tuesday afternoon, where we always are on Tuesday afternoons. And let's see who's joining us here. We've got a couple of different Instagram feeds here. We've got CNY's feed. We've got my feed. We've got LinkedIn and YouTube right here in the middle. Oh, and Facebook. Hey, good day. First person on Dos Diamantes. Hello, and Pretty Binky. Nice to see you, Cecilia and Melissa. Best of Millie. We've got Gail Schultz and Lo Laurie. Caitlin Clark for Consulting. Good afternoon. Emily Mortensen is here. Hi. Oh, you're going to be coming back soon. Nice to see you. Hi. Is it Nicey? Forgive me for mispronouncing. And Monica Ashley over here. Who do we have? Grace Tung is our first to join, and congratulations to Grace and Brock for hitting a little bit of a jackpot there. Certainly thoughts are with you. Hello, Zenaida. Nice to see you. And Melissa up there who was just in Syracuse. The Veers Pierce, glad to see you on our show this afternoon. Mrs. Savannah Townsend, we've got Barbara Brown, Cecilia Melissa's over here. Keely Kofsu, I see my beautiful mother and father in the great state of Alabama, where I will tell you my son got to go to the University of Alabama football game, the homecoming game. He went with my uncle this past weekend, and it was quite the event. My dear friend Maria in Miami, nice to see you here this afternoon. Hey, so how was your weekend? How's your week been? Over on Facebook, we've got Tamara, we've got Michelle. And nice to see you. Tamara says, I had a hysteroscopic myomectomy in May of 2023 to remove a polyp and a submucosal fibroid. We decided not to remove a fairly large fibroid outside of the uterus after several consults. The fibroid pushes on the fundus, however, does not affect the uterine cavity. I'm wondering if when I have my embryo transfer, should I let the doctor know ahead of time, especially regarding the placement of the embryo? Will it affect the FET and its success? Well, so the question there is about fibroids, and fibroids are very common. They used to call these fibroid tumors, and they're not tumors. They're benign growths. They're literally growths of muscle. And so the way a fibroid happens is that, so normally the uterus is a little hollow organ, right? And muscle comes together in sheets. And normally these little sheets form that nice little hollow organ. But sometimes the cells of the muscle can kind of get knocked off kilter, and that starts to form a ball. And that's exactly what a fibroid is. It's literally a ball of muscle. There are some different types of fibroids. Where they are located is how we kind of classify these fibroids. A fibroid that is inside the cavity is called an intracavitary fibroid or a submucosal fibroid. A fibroid that is in the wall of the uterus is called an intramural, that is in the wall, intramural fibroid. And a fibroid that is sort of on the outside part of the uterus is called a subserosal fibroid, subserosal. What you're describing there, Tamara, is a submucosal fibroid or actually, I guess you had a submucosal fibroid that was removed. And we do want to remove such a thing because we don't want that fibroid to disrupt the endometrium, the uterine lining, because that's pretty valuable real estate for where the embryo wants to implant, right? So we want to be very careful. About that. And so that's why we tend to remove those fibroids that are submucosal. What you're describing there is probably either an intramural fibroid or a subserosal fibroid. Typically, the doctor, when they go to do, or the provider, when they go to do your embryo transfer, we're going to see that with the ultrasound. So it doesn't really affect the placement of the embryo. We always kind of want to put that embryo in the same place. Sometimes the fibroid can push on the uterine lining and can distort it somewhat, but that doesn't necessarily mean it's going to cause trouble. Since we know that, up to probably 75% of women have some evidence of fibroids, they don't generally cause trouble that needs to be dealt with. Most of the time, the fibroids that people have are very small, but they can grow quite large and they can disrupt things. And when they grow large or they're disruptive, then that's when they cause a problem. We want to do something with them. Fibroids tend to develop their own blood supply, which can change the way the blood flows inside the uterus. And eventually that can have something to do with fertility, but also it affects the way people bleed. So people with fibroids tend to have heavy menstrual bleeding. But most of the time what we see, like let's say that you go off and you have an ultrasound that shows that you have a couple of fibroids that are 1 or 2 centimeters, those things typically don't cause any problem at all and really don't cause anything that needs to be dealt with. In your case, Tamara, I think that that's something that we would see when it came time to do the embryo transfer. But it, God willing, shouldn't have any impact on your outcomes. Had so many other people joining in here. Amber Vince, of course. Hello, Mrs. Vince from the beautiful state of Kentucky. Who did I just see here joined me? Somebody else. Yes, my friends in Miami. Somebody else I just saw there, and I said, "Oh yes, Norma Jeans." Everybody, and boy, I got all of Dade County on here today. By the way, if you're not aware, I am also the medical director of the Miami Center of Excellence, but I live here in Colorado Springs, full time in practice in the fertility and GYN practice here and at Cheyenne Mountain Gynecology. Miami is a place that I'll go back to sometimes. The practice there is a wonderful place to do monitoring if you live in South Florida and are planning on IVF, or if you just need gynecologic care. We've got some wonderful providers in that office, so can't recommend it enough. Let's see, Morgan is asking, how long after hysteroscopy can you start an IVF cycle? Morgan, the very next cycle. So if you've done a hysteroscopy in the month before, when you get your next period, you should be able to start IVF right away. Looks like Fatima is over here and says, what do we do for elevated NK cells? And do they just need a treatment in a medicated cycle and doesn't have to be IVF? So NK cells are called natural killer cells. And this is a form of an immune cell that we all have in our bodies. And the concern is, particularly for folks with infertility, and also sometimes even with recurrent pregnancy loss, is there something about our immune system that's revving itself up and trying to attack our own pregnancies, looking at our pregnancies as invaders and thus inciting an immune response. And that's what NK cells are said to do, natural killer cells. There is a blood test that you can do for natural killer cells, but to be honest with you, I don't consider it to be very accurate, because the activity, it's not so much the number of the natural killer cells, but rather what are those NK cells doing inside your body. And the treatment of choice for that is called intralipid. Intralipid is an infusion. It's basically an infusion of a solution of fats in the body that's a very potent anti-inflammatory. And so it is part of one of our, actually a few of our normal immune protocols here at CNY. And is something I would consider to be very useful, especially since we can't always test and tell who has NK cells that are going to be a problem. So do you have to do IVF with NK cells? No, not necessarily. NK, or rather intralipid can be done with timed intercourse cycles or with IUI cycles as well, because again, the goal is to try to decrease the activity of those natural killer cells. Again, that's what we use our immune profiles to try to treat. This comes from Shay Bonita. Does PCOS mean poor eggs? And the answer is no, not necessarily, but sometimes what happens is that when folks with PCOS, polycystic ovarian syndrome, so in nature they tend not to ovulate. You tend not to release eggs in the normal, predictable fashion. So there's the first problem. But the eggs that you do have in IVF, what ends up happening is that you are prone to being hyper stimulated. And if you are hyper stimulated, that means, well, the ovaries get very large. You make an awful lot of eggs. And that may not be a bad thing, because eggs are good. That's the whole point of the exercise, right? We're trying to get you to make eggs. But some of the data tells us that anything more than about 15 eggs is probably not going to be all that useful. That 15 seems to be the magic number that we're looking for in terms of egg quantity. And quantity is not necessarily quality. So you know what I mean there. If we do IVF for you and we retrieve 65 eggs, it's not surprising to me when 50 of those eggs are not good, or they're immature eggs, or they can't be fertilized. So I would say, no, it's not the same. That PCOS is not the same as poor egg quality, but when we overstimulate or with hyperstimulated eggs, those eggs tend to be not as good. Let's get over here to some of our Instagram friends. Hello, Nurtured Shanna. It's so nice to see you, and I love to look at your postings on Instagram because they are always so very insightful. Can you please speak to the role of estradiol after transfer? My previous transfer, it was above 1,000, but this time it's 118. In both cycles, I've been told this is in the normal range. So yeah, really good question there. So estradiol, the estrogen levels in the blood as they pertain to embryo transfer are really pretty irrelevant, to be honest with you. We test them because, as I've said here before, if we didn't, then people on social media start screaming about it. I want to know what my estradiol is, and why did they tested yours, but they didn't test mine. And so it's just kind of a thing that we do. The only point of the estrogen as it pertains to your embryo transfer is, did it make your uterine lining thick enough? And if it didn't make your uterine lining thick enough, then you need more estrogen. If it made your lining thick enough, doesn't matter what the number is. Now, that's a little different if you are talking about doing a fresh transfer, because if your estradiol is greater than 3,000 at the time of your retrieval, then usually that means that the endometrium is going to be somewhat of a hostile environment for your embryo. And so in that scenario, we don't recommend that you do a fresh embryo transfer. But as it pertains to a frozen transfer, the estradiol level, to be honest with you, Shanna, really, it doesn't matter so much. So all we want to know is, did it make your lining thick enough? That's important. Let's see what we got going on over here. Lady Lewis Jr., hello, and Candace Lee. Let's see, PCOS, and this comes from Glove78. who has a wonderful little picture there. And in fact, and it's a picture of a Star of David, and it says, "Never again is now." And, and I should have said this at the onset of our talk here. Our thoughts absolutely go out to our friends in the Middle East, and in the state of Israel, and the folks who are all suffering with a lost family, folks having been kidnapped, and even the folks who are involved in not having enough to eat or enough water right now. Our hearts and thoughts go out to all of you, but especially to those in the nation of Israel. If you don't mind me saying something that may be considered politically unwise, don't want to get too involved in that conversation, but certainly our thoughts go to the Holy Land and all our brothers on that side. Okay, but the question there anyway, sorry, was PCOS and a low AMH. Any chance for IVF? The answer is absolutely. Yeah, so the AMH level is often elevated in people who have polycystic ovarian syndrome. Typically, we think of it as being above a level of a 5. If it's above a 5, then we think, oh yeah, you know what? That means your ovaries are going to kind of behave like PCOS. And in that case, we typically lower the dosage of medication that we use to stimulate your ovaries. In someone who has PCOS whose AMH is getting lower, it means diminished ovarian reserve, and there are some specific protocols that we use related to diminished ovarian reserve. So, is there a chance with IVF, my friend? Yes, absolutely. There is. Ms. Understood. Oh God, I love that name. That's really cool. Ms. Understood 82. Hello, KN Kendall. Possible adenomyosis. What are your thoughts? What are the protocols and medications you recommend in the months before embryo transfer to combat this? So adenomyosis, as we have talked about here before, is the process whereby the glandular lining of the endometrium ends up dropping down into the muscular part of the uterus. And so, we've got a uterus that's a piece of muscle, and inside that muscle is a glandular lining, and that glandular lining functions like your baby blanket. So that's what envelops the embryo, and that's the place that your embryo grows. Well, so what happens with that is that the glandular part can grow into the muscle, grow that way, or can even grow down. And so many folks who have adenomyosis have painful periods or can have very heavy periods as a result. It used to be that we were only able to diagnose adenomyosis after having done a hysterectomy, so after the uterus is out. Now there's some pretty clear, and with the advance of modern ultrasonography, we can usually see some evidence of adenomyosis, but the definitive diagnosis can also be made by MRI of the uterus. But what is it doing? It's said to disrupt some of the blood flow and to disrupt some of the endometrial lining of the uterus. And so what would we do about that if we knew it was there? Well, good question, but particularly in those who have had unsuccessful embryo transfers, they've had implantation failure, usually we recommend the same kind of treatment that we do for endometriosis before doing the embryo transfer. So if you have endometriosis and you've had recurrent implantation failures, we'll usually recommend 60 days, a minimum of 60 days of suppressive therapy. And so that can be in the form of Lupron. Lupron is an injection that you get that's long acting typically, that really shuts down all of your hormones. It has a kind of an unpleasant side effect profile in that regard, because basically it's putting you into a temporary menopause. So nobody really likes that very much, but it does the job. It will shut down the inflammation that's associated with endometriosis or adenomyosis. There are two oral medications that we will also use to treat endometriosis and adenomyosis. One is called Orilissa, and the other is called Myfembree. Myfembree is a drug that's taken once a day, and it is my preference because it has the lowest of the side effect profiles. Plus, it's just way easier to take a medication once a day than it is to have to take something more than once a day. But Orilissa is usually taken twice a day. So suppressive therapy is what we're looking there for adenomyosis. And for endometriosis. The Fertility Friends Foundation joined, so that is fabulous. It's good to have you. Um, let's see, how many chances is for my wife? She'll be 44 to be pregnant. Well, and forgive me, I got a little eyelash thing going on here. So, oh my God, where's the Oh, okay, sorry. Whew, that was close, man. I almost lost you there. At 44, fertility is definitely an uphill battle. Um, um, Even in nature, it's difficult for us to get pregnant at 44. And not only is that because the number of eggs that we have is rapidly diminishing, but also because the DNA, the genetic material in those eggs, is becoming less stable. So the odds of success at 44 with IVF are honestly a small fraction of less than 1%. So it is a low chance for pregnancy, but that doesn't mean it's a zero chance for pregnancy. So these are things that we like to talk about when it comes to doing a consult, so we can kind of look at some realistic numbers given some of the hormonal situation that you might have in your family, because that allows us to kind of narrow it down a little bit better. What it is certainly not is an easy road to pregnancy, just like trying to get pregnant at home at 44 may not be an easy road either. And the reason for that is that it likely will take more than one cycle. So there was just some evidence that came out looking at, well, the question is always, well, how long is this going to take? And what am I going to have to do in order to get pregnant, especially if I have a very low ovarian reserve, which is kind of what I would expect at around 44. And so this study looked at folks who have an AMH level, an anti-Mullerian hormone level of 0.3 or less. And basically, what it showed is that after 3 cycles of IVF, your pregnancy rate starts to approach that of folks whose AMH is greater than 0.3. So I know that's not a lot of information for you, but 3 is a good number of cycles to kind of have in your mind to say, this is what I think you may need to do in order to get what you're after. Most folks would like to say, I want to do 1 cycle of IVF. I want to get my egg. I want to make my embryo. I want to put it in and I expect it to stick. And if it doesn't, well, obviously something is not right. Well, when it does, that means you got pretty lucky because IVF is absolutely a numbers game, but those numbers become a lot more critical as we approach our mid-40s. So best of luck to you, my friends. Let's see. Barbara Brown is transferring on Thursday with me. Thoughts on Neupogen wash and the HCG wash before? Yes, indeed. The HCG wash is something. HCG is the pregnancy hormone, human chorionic gonadotropin, and what we do with HCG when we do a wash is to place it inside the uterine cavity. It goes on to the lining of the uterus and increases the expression of some of the proteins and things that are associated with implantation. So we do believe that it helps with implantation, and there is some evidence to support that as well. As far as Neupogen is an immune modulator, and that would be particularly useful, Barbara, for folks who have had recurrent implantation failure or recurrent pregnancy loss. A Neupogen wash is not something I would typically recommend as a first iteration in someone who is trying to do an embryo transfer, but certainly for somebody with a history, the Neupogen wash makes a difference. The other thing I think that's probably even more important than a Neupogen wash would honestly be a PRP wash. PRP is platelet-rich plasma, which we can use for all kinds of things in the world. You can put it in a sick joint. You can put it into a scalp and regrow hair. You can use it with filler to help, in facial aesthetics, and we can put it in the uterus because we can put it in the ovaries. That's sort of considered to be what they call ovarian rejuvenation. But used inside the uterus, as I am fond of saying, this is the most healing salve we have for the uterine lining, and it comes right from your body's own tissue. So that's a good thing. Nick Betez, I believe that says, fourth time trying the fourth stim. Cysts keep showing up in the ovaries instead of follicles. Doctor wants to flush out. Should I get them removed? Well, so that term ovarian cyst, it means a lot of different things to a lot of different people. So let's talk a little bit about the ovarian cyst there, Nick. I want to kind of go back to just sort of gynecology in general. If you have ovaries, pay attention to this because this is important stuff. You make cysts in your ovaries pretty much every single month. Now, sometimes these cysts can get large and they can be difficult. They can be problematic. What is that cyst? That is your ovarian follicle. The follicle is a little sac that's lined by some cells that are called granulosa cells. Granulosa cells are the cells that make your estrogen. And there is usually an egg inside that little sac. There's some fluid inside the sac, and the purpose of that fluid is so that it can function like a squirt gun when it comes time to release the egg. It goes, and it does actually make that noise too. If you listen very carefully, you can hear it make that noise. It functions like a squirt gun because the ovary squeezes out, it ruptures the skin of the ovary and squeezes out the egg. The egg kind of floats around and ends up getting taken up in the fallopian tube, where hopefully, if you're trying to get pregnant, there's some sperm swimming around and they meet together in the fallopian tube, and that's how an egg gets fertilized. That fertilized egg then kind of floats its way down into the uterine cavity where it takes up residence, and that's how your pregnancy proceeds. When that ovary of yours releases that egg of yours, that is known as, anybody? Ovulation, right? That's ovulation. Bueller, anybody? Bueller. That is ovulation. And so when you release that egg, sometimes that's a painful experience. And that painful experience can be felt as ovulation. It's called Mittelschmerz, and that's a German word that means painful ovulation. When the ovary releases the egg, it leaves behind a space, and some people will call that a ruptured cyst, when in fact it's really just the releasing of the egg. When the ovary releases the egg, it leaves behind us an empty space, and your body hates empty spaces. And so, but it's like a car leaving a garage. It leaves an empty garage. So what does your body do with that empty garage? Well, if I had an empty garage, I'd fill it with junk. I'd put all my stuff from the closets and the things that I refuse to throw away. I'd stack it all in the garage. Your body fills that space with fluid. And that's a different type of cyst. Sometimes that fluid can be blood, and that's what's called a hemorrhagic cyst. And guess what that does? It hurts because it's putting stretch on the thick lining of the ovary. It's stretching it out, which makes it not feel so good. And that can be a painful cyst as well that can lead people to go into the emergency room. But it always bothers me a little bit when people say that they have cysts and they had to go to the emergency room, because what I have learned in a couple and a half decades as a gynecologist is that women go to the emergency department with a variety of different things causing pelvic pain, and they will often be imaged in some capacity. Sometimes they'll have an ultrasound, and sometimes they will have they will do a CAT scan, and they'll be told that they have a cyst. And then they think forever that they had some pathology going on inside the ovary and that something is wrong with them because they had the cyst that was really just a normal functional part of the menstrual cycle. Now, there are cysts that are not normal parts of the menstrual cycle. People can have growths in the ovary that are usually benign growths, but they can be persistent cysts that are not hormone secreting and don't have an egg in them. And those things, once they get to be above about 5 centimeters, we start thinking that, I think it's a good idea that you get that looked at, that we maybe think about having a little laparoscopic surgery to take that cyst out. Because when it gets above 5 centimeters, we worry about it twisting on itself. And if it twists, that becomes a surgical emergency. That's called an ovarian torsion. Now, what about these cysts that we find at the beginning of an IVF cycle? Well, where are those coming from? Because that doesn't sort of fit anything there. Usually what's happening there, Nick, is that these are, they're often leftover follicles from the cycle before, or a little egg that's getting stimulated a little too early in the cycle. So and that becomes much more common as we mature. So women in the upper 30s and in the 40s, we see that more commonly. What do we do about that? Well, we check a blood test. And if they are hormone secreting cysts, then usually we can suppress that with a little birth control for short term. If they are, so I'm thinking 2 weeks worth will kind of help the ovary to keep quiet and allow those cysts to go away on their own. Or if they are not hormone secreting cysts, then we can go and do a little procedure. Usually we do it under some sedation. It's the same thing as we do with an egg retrieval, and that's to place a little vaginal ultrasound with a needle on it and just suck out the juice in the little cyst there, because that they can take up some space that can prevent the other eggs from other follicles from being able to grow. And so it's useful for us really to be able to do that. So that's typically the way we go about those. Is it hormone secreting or is it not? And that gives us some guidance, but that's where they're coming from. They're usually left over from the prior cycle. Hello to Unshakable Woman. I like that. That is a very nice name to have there. Oh, let's see what we've got going on here. From Lucy Marie, any thoughts on Lupron for suppression prior to a medicated frozen embryo transfer? So, it depends on what you're suppressing. So there are some people, it used to be for embryo transfer cycles that we would, everybody would get suppressed before we start. We'd want to shut down the ovaries. Everything was medicated, and there's no evidence that that's necessarily a good thing now. So I don't usually recommend that across the board, but there may be scenarios where it's important. But Lupron, as we just mentioned, is an important suppressive device for things like endometriosis and adenomyosis. Hi to Eileen Bailey and lovely husband Ellis, who just got back home from Colorado today. And Eileen is sending prayers out to Israel as well. Thank you, my friend. Alexis in Miami, a nurse practitioner extraordinaire, is here with us. Oh, and hello to Brandis from ASRM. So ASRM is the American Society for Reproductive Medicine, and they are having a big conference in New Orleans this week, started over the weekend and lasts through kind of midweek, I believe. And Brandis is lucky enough to be there with some of our other CNY colleagues, and has left me here by myself to do all the retrievals and transfers and consults and clinic visits. And so thanks for that, Brandis, and I hope you're having a great time. Okay, let's see what else we got going on here. Sorry, I got to move this over because I can't see the computer. No audio on Instagram. Well, somebody just told me that there was no audio on Instagram, so I just pulled out some microphones that I was using. Not sure if that was happening before. And maybe that was the case. That's why there aren't so many people on CNY's Instagram page. So sorry about that, but hopefully we are back and you can hear me. Let's see. Violet Joy had 9 transfers and 4 losses. I have done testing and immune and PRP and HCG, but no baby. I'm getting ready to do my 10th transfer. What should I do next? Well, that is a difficult scenario to be in, isn't it? Let's see. I'm just curious over here if anybody said anything about, I hope I have some, fixed audio, no audio for about 6 minutes. And it was all the way down at the end of my at the end of my things here, so I couldn't see. So probably everybody's dropped off the CNY side. My apologies. Um, Violet, you present a difficult scenario there because you've had so many transfers. A lot of times there's not a good reason why these things happen. I wish that we could figure out why that is the case, but sometimes we don't know. So recurrent implantation failure, we always kind of start thinking about. Um, well, what's the cavity look like? So we do a hysteroscopy or a saline sonogram. We start thinking about, is there endometriosis? And so we think about doing either a receptiva test or a laparoscopy. These things are important because they can stand in the way. We think about increasing the the autoimmune profiles. And even in your situation, maybe the big guns like IVIG, which is IV immunoglobulin, kind of the biggest gun that we have as it pertains to an immune modulator. And of course, at the end of the road, when we can't figure out what else has been going on, we often think, well, I wonder if it makes sense to think about using a gestational carrier instead. As much as we know, in fact, I have to tell you, every day that I learn something new, that I learn something that I didn't know, it teaches me more about what we don't know. There may be some reason that we just can't find as to why these things don't work. Now, most of the time, what we do works in the majority of people, but sometimes it doesn't for reasons that we can't understand. And when that's the situation, we start thinking about maybe a gestational carrier is a good bet for you. So something to consider there. Lisa Wright, I just had a laparoscopy done and was told I have an ectopic pregnancy. How can I prevent that once I'm starting to conceive? Okay, so I guess what happened there, Lisa, is that you had a hormone level that wasn't going in the right direction, and maybe they saw something with ultrasound, so they decided to do a laparoscopy and take care of the ectopic pregnancy. An ectopic pregnancy is most of the time a tubal pregnancy, but they can be in other locations as well, where the pregnancy grows where it can't. So a pregnancy can't grow in that fallopian tube because the tube is a small place. There's a limited size and a limited blood flow. And so as the pregnancy gets larger and larger, eventually it will rupture. And when it ruptures, that can be a potentially life-threatening situation. What causes an ectopic pregnancy? It is typically damage to the fallopian tubes, damage to the tubes. How do those tubes get damaged? Most of the time it happens as a result of an infection that you didn't know that you had. And those infections can create inflammation and damage in the tubes. And what happens is that when the sperm swims in and the egg has been picked up at the far end and the two meet and create a fertilized embryo, that instead of transferring itself down into the uterine cavity, it hits a roadblock and it gets stuck. And when it gets stuck, it's got no place else to go. So it just takes up residence there. And hopefully that's something that we find before it starts causing you trouble. So here in the fertility world, we are very aggressive about identifying ectopic pregnancies early because, again, they're potentially life-threatening. Is there anything that you can do at home to prevent an ectopic pregnancy? Unfortunately, the answer is no. Even with IVF, where we're not using the fallopian tubes, there is still a low, 1 to 2% risk for an ectopic pregnancy. So we still follow that very carefully. If you have had an ectopic or a tubal pregnancy, your risk for having another ectopic pregnancy is unfortunately very, very high. So what that means is that when you get pregnant again, from the very first moment that you know you have a positive pregnancy test, we would want to be following those hormone levels. We expect the beta HCG to double every 48 hours. And that's really kind of what we're looking for there. So, gosh, I feel so bad that we lost so many of our viewers on the CNY side, that the audio was gone. Gina Glow Up, hello to you. Nice to see you. Megan Downey said, I have a leftover follicle, so I couldn't start my Clomid this month. Is that common? Unfortunately, it is. Now, I will tell you that most places don't even look again to see if you have a leftover follicle, but if you do, you run the risk that it's going to kind of take up all of your medication, and that it can sort of stand in the way of the ovary being able to make an egg. So usually if there's a leftover follicle from your last cycle when you did ovulation induction, we like to wait and let that go away. But it doesn't put you behind for very long, Megan. Really probably just a month at most. Mind Girl Health. I like that name too. Rue 8200, thanks for coming back. You have had, oh my gosh, 3 back-to-back ectopic pregnancies. So you have no fallopian tubes left. The first was in my right tube, the second in the remainder of my right tube, and the third in my left tube. How can I ensure that this doesn't happen in IVF? Well, so I will tell you there that IVF is kind of one of the solutions. It's not a perfect system. So as I said, there's still probably a 1 to 2% risk of an ectopic pregnancy through doing IVF. But again, compared to, after 3 ectopics there, if you still had tubes, you'd probably have about an 80+% risk for a recurrent ectopic. So to say that something has a 1% risk is a far cry difference from what you're talking about there, my friend. There's 3 different ways that we can treat ectopic pregnancies. And since we're on the subject, let's do this here. We have about a little bit more than 15 minutes left in the program here today. So glad everybody's with me. And again, my apologies for the audio problem over here on the CNY side. How do we treat ectopic pregnancies? One way is that if you meet certain criteria, there's medication we can use, which is an injection that's called methotrexate. And methotrexate will cause that pregnancy to go away. That's often the preferred method when possible, because the other methods are surgical. And obviously, if we can avoid having to have surgery, that's probably a good thing. If we're doing surgery, one choice is to do what's called a salpingostomy. A salpingostomy is where we make an incision in the fallopian tube and take the pregnancy out and let the tube heal on its own. Unfortunately, that does increase the risk for future ectopic, whereas the other choice is to do a salpingectomy. And a salpingectomy is where we ectomize, is to remove the tube. And it looks like, Rue, 3 salpingectomies aren't too fun. Doesn't sound much like it, but trust me, it was better than the alternatives. So, with IVF, we follow those hormone levels very, very carefully from the very get-go. So we have yet to miss an ectopic. In fact, no fertility clinic should be missing an ectopic, because we're following hormone levels from the very earliest of positive there. Let's see. It looks like Marcelina is here with us. Is 1 month of Lupron depot enough to suppress endometriosis? The evidence shows us that 2 months is really ideal. And what they're looking at there is a marker that lives inside the lining of the uterus. The marker is called BCL6. And BCL6 is being expressed when you have the inflammation coming from endometriosis. So when we treat that with 60 days worth of suppression, your odds of a successful transfer go from less than 10% to greater than 60% in the very first month after your treatment. So 2 months is probably a good idea, because it's very evidence-based. Now, I suppose something is better than nothing. So is 1 month okay? Well, I can't tell you it's bad, but I'd rather see you do 2 months, if that makes sense to you. Let's see, Yadira, is it better to transfer a day 6 embryo to 2AC then 1 day 5 for AA. No, that 4AA embryo is going to be your highest graded embryo, and a day 5 blastocyst is always going to be, theoretically, should do better than than either a day 6 or a day 7 embryo. The difference between day 5 and day 6 is very subtle, but it's there. The difference between anything in a day 7 is more substantial. So I would go there with the day 5 for AA. Claudia's here with us. Have I seen, says Claudia Barron, have you seen success with IVIG? Yes, I have. IVIG as the big gun immune modulator is is very expensive. So to be honest with you, if it weren't so expensive, I think we would probably want to put everybody on it to some degree, I would think, because it's so very, very useful in shutting down immune things that we may not fully understand. It is not FDA approved for the use of people trying to get pregnant, so that's not technically what it's for. And as a result, insurance most of the time doesn't cover it, but sometimes they do. And oftentimes our folks at CNY have a little magic that they can work to try to help find discounted places, or sometimes on some of the on some of the social media groups, people will have some leftover and will sell it or give it away. And so that's an option too. Yes, I have seen success with IVIG, and I think it's certainly a good idea when it's necessary. Here's a good question, again from Shanna. How concerned about heat should I be after transfer? Is being outside for a while when it's warm okay? And I would say yes, that's okay. What we really want to avoid, though, is things that are going to dramatically increase your core body temperature. So that would be things like saunas and hot tubs. And so that's why we tell you to stay away from them. Can you take a bath after an embryo transfer? Well, you know what? The current wisdom is there's no reason you can't bathe, but let that embryo implant first. And then, a bath, I would always tell people, you want to be in something that's not going to be making you sweat. So if you're sitting in a 110-degree bathtub and you're sweating up a storm, that's probably not a good indicator that your core body temperature is normal. So, but otherwise, being outside in the heat is okay there. Here comes from Nick. My AMH is 0.2 at 39 years old. Should I assume that the DNA of my eggs is diminished? I have 12 frozen embryos trying to get more. So there, Nick, you've got sorry about that. You've got a diminished ovarian reserve. The ovarian reserve doesn't necessarily speak to egg quality. But at 39, we would expect that probably 50% or maybe even fewer of the eggs that you produce are going to be normal. So I would, there are a bunch of supplements and things that I would recommend that you consider doing if you're looking to make some more embryos. Things that we really want to focus on for egg quality. Brock is here with us, who I mentioned a little earlier. Hello, Brock Tongue. Our cryo report was uploaded. We have 3 day 5 embryos and 7 day 6 embryos. I don't know much about day 6 embryos and I'm anxious. Well, I certainly understand why you're anxious, because there's not a whole lot in this process that doesn't produce anxiety. You know what? So I think you're probably in good company here as far as anxiety goes. Again, a day 5 embryo is the earliest point at which an embryo will become a blastocyst. And what is a blastocyst? A blastocyst is a little functioning machine. It's a little piece of machinery that's doing its job, making chemicals and just trying to live its life and continue to grow. And at that point, it's starting to look for its mother, right? So a day 3 embryo, there's nothing wrong with a day 3 embryo, but it's still a bunch of cells that are trying to cleave. They're trying to divide and figure out how to grow. And some of those day 3 embryos will not grow themselves to become blastocysts, as we know. So the fact that it's made it to blast is a good thing. Um, and that means the blastocyst has a higher probability of being able to get you pregnant. Now, folks, our friends here have used a donor, and they're talking about the embryos created with the donor eggs. And so they've got day 5 embryos and a whole bunch of day 6 embryos. As I just mentioned, there's only a little bit of difference between a day 5 and a day 6 embryo. Day 5 is always preferred. Not a big deal to transfer a day 6 embryo. And in fact, if you have a blast that's a day 7 embryo and that's all you have, I'd say good enough. Let's do it. But a day 7 embryo statistically is not going to perform as well as a day 5 or a day 6. So congratulations, Brock. And I think that is awesome news there, my friend. Let's see what else. Oh, Carly is back. Hello. It's almost time to go. We'll look forward to seeing you next month. Just double checked. The CNY video still has no audio. Well, oh, maybe that was from a little bit earlier. So hopefully there's a bunch more people on the CNY side. So hopefully people can hear me now because people are still joining in. Lots of names. Emily B. Ooh, I like that name too. Lindsay Jordan will see me on Thursday. I can't wait. That is good. I'll make sure to do my hair and makeup. I'll be prepared. Looks like Linenkin. If you just started stims, are you still able to opt in for a natural transfer as long as your levels are average or above average? Well, if you're planning to do a fresh transfer, then that's going to be a medicated cycle. A fresh transfer is a medicated cycle because we've done all that medication as far as the stimulation goes and given you, you ovulated and made a whole bunch of progesterone. So that's a medicated cycle. When we talk about natural, a modified natural, or a medicated cycle, generally we're talking about frozen embryo transfer cycles. So if you don't get pregnant with your fresh transfer and you go to do a frozen, that's when the natural cycle would really come into play. Back to the Facebook side. Let's see. Vilma is here with us. And I just lost you, Vilma. Where'd you go? Man, here we go. I am 40 and my husband is 43. We get 5 embryos per cycle. Do we transfer day 3, day 5, fresh or frozen? Lining is always on point. No HSS. Multiple failed day 3 transfers. Should we try PGT next? Well, at 40, we're going to have a big issue with making normal embryos. So that's going to be the first thing that I would think about. If you're limited in the number of embryos, I would always go with a day 3 embryo. Day 3 is always going to be a better choice because that embryo will always do better. If it's going to grow, it's going to grow in you, and growing in you is always a better place than growing in the laboratory because it may not grow in the lab, whereas it does grow in you. So the only thing that I would caution you about is fresh versus frozen. In our 40s, the success rate with a frozen embryo transfer is much higher. Significantly higher than with a fresh embryo transfer. So not to say that you can't do a fresh, but I would, if you ask my opinion, I would say don't do fresh, do frozen, because those embryos are precious little things, and the body just does better when it's had a chance to recover and it's not so much an egg making mode. Now at CNY, the fresh transfer is included in the price, and so there's a financial incentive to do it fresh. And this is a good thing for many people, but again, after 40, it is not as good a thing. So let's see. Ariel is here. Hi, Ariel. 12 weeks this week. Woohoo! That's fantastic. I'm so glad to hear that. You saw the baby yesterday, growing beautifully. Oh, thanks for saying this, Ariel. Grateful to CNY and the affordable prices. I would have never been able to afford 3 rounds I did without these prices. Well, that makes it all worthwhile, my friend. I am so happy to hear this wonderful news and that we were able to help make a difference in your life. Let's see. I've got Ethan here. Wanted to ask about reciprocal IVF, natural from one person, and modified natural for the recipient. So reciprocal IVF is usually used in same-sex female couples where the egg donor is one member of the couple, and she goes through the stimulation, and we create the embryos, we typically with donor sperm. Well, I guess female couple, it's always with donor sperm. We make those embryos, we grow those embryos up, and we place them back into the other member of the couple, the recipient or the gestational carrier, as we call her. So that's reciprocal IVF. Usually, and you can definitely, as a recipient, do a natural or a modified natural cycle, but it will be with a frozen embryo, because if we're trying to do it with a fresh embryo, then correlating two people's menstrual cycles, they're never exactly alike, and it is unlikely that being able to get those cycles synchronized will be particularly possible there. Lady Gemello wanted to ask about reciprocal. Oh, here we go again. See, timing is everything. I've natural from one person, and I think you're asking the same question. Natural for one person and modified natural for the recipient. So I think you're talking about a natural cycle IVF. If that's what you're talking about, a natural cycle IVF is that we don't give you any stimulation, that we're just retrieving from a natural follicle. So typically it means you get one egg. It's not something that I typically recommend for people because it costs the same thing as regular IVF, where you may get, hopefully you get multiple eggs. But in a natural cycle, we just draw from your one natural follicle, which may or may not have an egg. So the most you typically get would be one. And then that modified natural for the recipient, as long as the embryo is frozen, that can be done. My friend Maeli is here. How common? Oh, and she just told me about this news. She transferred one euploid embryo, which means it was a blastocyst. And I don't know if it was a day 5 or day 6 embryo, but several days after that implantation, that embryo split, and she now has twins. And so God bless you, my friend. Yeah, it happens. The day of splitting is typically, if I remember, between days 9 and 11. So that embryo is already going to be back inside of you. So we can't see it at that point. So that's one of the reasons that we recommend, that we don't recommend folks transfer more than one euploid embryo, because each euploid has a very high, 60% probability of being able to get you pregnant. And when that's the case, 2 can become 4, and 4 can become 8. And by that time, we're talking about catastrophe. So I'm very happy that you have 2 in there, and we'll keep our fingers crossed. Hello to Richie. Nice to see you this afternoon. We've got a couple more minutes to go here on Fink and Friends. Hi to Lizzie Chow. 5 of my 9 made it from yesterday. Awesome. Thank you for taking care of me again. It is my pleasure and my privilege. Let's see. LM Simon says, I have my midway blood work for my second natural FET tomorrow. Fingers crossed. Oh, it's not tomorrow. Fingers crossed for good news on Monday. Yes, indeed. Fingers crossed there, my friends. When does CNY release patients to the OBGYN? Typically, that is at about 8 weeks of pregnancy. Now, sometimes it's earlier than that because people have a relationship with their doctor and want to, establish their OB care a little earlier. But and sometimes we have to hold on a little bit longer if they're having trouble getting in. But typically, at about 8 weeks of pregnancy. Well, we are back up here to the top of the hour. I am so sorry that we lost some audio on the Facebook, on the Instagram side here, but thanks for sticking around, or thanks for coming back. Every Tuesday at the same time, 4 p.m. Mountain Time and 6 o'clock on the East Coast, it's Fertility with Fink and Friends, where I do my doggonedest to try to get your questions answered. And if you'd like to email me with some questions, I try to get them in before we get to air here. I'm happy to try to get those questions ahead of time. I don't know that I'll be able to answer them for you before we go live, but rfink@cnyfertility.com, or better yet, better to Instagram me at randyfinkmd, and please follow me on that Instagram page if you haven't already. We try to do some fun stuff on that Instagram, keep you laughing, keep you smiling, and keep you hoping. Because as I always say, fertility and this journey is not your book. It's not your novel. It is merely a chapter. And what are we doing here? We're helping you to rewrite that chapter. So until next week, thanks so much for being here. God bless to everyone. Our love goes out to the state of Israel, and I wish you all good night.